let me get started here. I want to show you this picture. This is a table at the annual conference of the World Professional Association for Transgender Health. And this was the banquet on the last night of the conference. The point of this slide is not to try to figure out, who's transgender and who isn't, but really to show you that transgender people look like a whole range of different things. So let's talk about some terminology, because I think a lot of people, the first thing they say, when you're talking about transgender people, they're like, I don't even know what terminology to use, Transgender, transsexual, what's a cross-dresser, what's a transvestite, and I just see in charts that I read, just working in the hospital, and I'll see someone who's trans, and I'll see, 2 years ago they saw the podiatrist, and they're like, this is a cross-dressing male or something, and it's just like, we have to define some of these terms so we know what we're talking about. And, for the most part, this could be like an entire semester course in women's studies and gender theory. And so, the bottom line is that transgender is this umbrella term that really refers to people who have some kind of gender presentation or gender identity that's different than what you might expect of someone who was born with that body. So some terminology, some additional terminology. So female to male would be somebody who's assigned female at birth and they're transitioning into some kind of male spectrum. And male to female or transgender woman would be someone who's male assigned at birth and transitioning into some kind of female spectrum. So when you say a transgender man, you're talking about somebody who is assigned female at birth and has some kind of male gender identity. So you identify people with the targeted or affirmed gender. So, and you'll see how this comes up in a minute when we talk about identity and sexual orientation. But so if somebody's assigned male at birth and then they're having a female identity, they would be called a transgender woman. If that person is attracted to women, they would be considered to be a lesbian. And then vice versa, somebody's in a female body and then they transition to male and they're attracted to men, so they'd be called a transgender male. And then if they're attracted to men, they would be a gay man. So I think the most important piece, again, individualized. Every transgender person is different. Some transgender people don't even believe in a binary of male or female, and they try to move beyond that. Let's take a look at these different spectra of identity that exist. So let's jump down first to gender identity. So your gender identity is kind of your core, who are you on the inside? It's like what's in your mind, in your brain. How do you identify? Are you male or are you female? And you'll notice that there's a spectrum. What we try to do, medical providers, and what transgender people, myself included, are saying is that, well, I have a physical sex, but my gender identity, they don't match. So what happens is your biological sex, that's your chromosomes and your gonads. Do you have ovaries, do you have testicles, are you XX or XY? There's really nothing we can do to change that. It's generally one or the other, although there are people who disorders of sexual development, intersex, who kind of land in the middle. Can't really do much about that yet. But physical sex is those secondary sex characteristics that I was just talking to you about. And so those, if you're here in your physical sex characteristics, but your gender identity is over here, well, then we have a problem. And so we have to try to resolve these two things and link them up. And that's when transgender people will seek medical care. So we talked about these, about how to identify people. Lesbian, transgender woman would be a MTF, so male to female spectrum person who's attracted to women. And then vice versa for a gay transgender man would be female to male spectrum attracted to men. So we're learning terminology and we're implementing it. 2 slides later, it's like being a resident. See one, do one, teach one. So transgender people, I've mentioned to you that they seek a transition. So transgender people seek different kinds of services and different kinds of care. So transition has a number of different pieces to it. So, so there's, I think people tend to, for the most part, focus on the surgical, which is kind of the third in the list. And I put these in my opinion, what the order of priority is, So the third one is surgical. I think the most important priority that often gets overlooked are the social pieces of transitioning. Like prescribing hormones, it's like it's a pad, a prescription pad. You give them the hormones, they take them twice a day. It's magic happens, that's the end. It's really easy. Surgery, you go in, you have surgery. It's some surgeon who's done 500 of these procedures. They do it, recover for a couple of months, you're done, that's it. But the social transition, Let's say you're 32 years old, and you have a whole life, you have family, you have a career, profession, whatever, and then you transition and you have to suddenly start navigating your entire life from the perspective of a different sex. That's a big deal. You didn't have the benefit of like puberty in that sex unless you're a kid, and talk about that. So it's really complicated. You have to come out to family, to friends, your grandma, your neighbor. It's really difficult. And so that's really the biggest focus that I find in my practice is I wind up doing about 90% case management and like 10% medicine. How many transgender people are there? Well, there's been some initial data from Europe is really flawed, and the way that they collect the data really underestimates the prevalence. So in 2012, there was a study published in the American Journal of Public Health. They called 28,000 people in the state of Massachusetts on a landline, and 0.5% of the people who answered the phone said that they were transgender. So that's a big deal. That's 1 in 200. And the Williams Institute at UCLA did an estimate based on a bunch of different quasi-scientific data of varying quality, but 0.3% was their estimate, the US adult population transgender. So we're talking about like 1 in 200, 1 in 300. So it's probably an underestimate. But it's important enough to know that there are a lot of transgender people out there. So, let's talk about, so now we kind of have an idea of how many transgender people there are. So let's start talking about some of the, issues. Why are we worried about transgender care? What is the problem? Why do we need to concern ourselves with transgender people? There's a lot of underserved populations in this country, a lot of people really lacking a lot of basic services. Why is this population important? I already told you that it's a whole broad range of people. Here comes Honey Boo Boo, right? Some people from all over the spectrum. So some transgender people, maybe they're really well off and they have plenty of healthcare access. So Transgender Law Center, based in San Francisco, did a study of 646 transgender people in California in 2008, and this is what they found. So if you look over here on the left-hand side, they found that 33% of transgender people were denied surgery, and 27% were denied hormones. So you could see somebody saying, like, well, that's not unreasonable. Providers haven't learned how to do this stuff yet. We can't complain too much about that. That points out that we need to have more providers trained, but it doesn't necessarily, I don't know that it's a direct disparity. Okay, but 21% were denied counseling and mental health services, so that's a real big deal. If you look in this box that I put over here, the box is my emphasis added, 15% were denied gender-specific care. So by that I mean pap smears in a transgender man, or prostate exams in a transgender woman. So transgender man, born female, now living as male, yes? So they saw the cervix in many cases. They need pap smears. So, 15%, so that's what, 1 in 8, 1 in 7 transgender men been told, nope, can't have a pap smear, sorry, go let your HPV percolate. So the National Transgender Discrimination Survey was kind of a larger version of the Transgender Law Center's survey. So this is a sample of 6,000 people from all 50 states and some of the territories. Half of the respondents, 50%, reported having to teach their provider about transgender health. So that's bad, 100 plus. If you just look at the graph qualitatively, there's a lot more dark blue at this end, which is the lower income range, and a lot more light blue, or there's a lot more dark blue at this end than there is light blue. What that says is that there's an income disparity among transgender people, that they're making less than cisgender people. And so that starts to explain, well, this is maybe why they don't have as much insurance, because they have less income, they're either under or unemployed, or they're employed in lower socioeconomic employment areas where there's less likelihood to have insurance coverage, which is a huge problem if you ask me, but I don't want to drag my socialist politics into this. So if you look at unemployment by race, so now we know that transgender people are underemployed, they have lower incomes. The general population of the US had a 7% unemployment at the time of the study. 14% of this sample was unemployed. You're a transgender person in the United States, you have double risk of being unemployed compared to a non-transgender person right off the bat. Now if you start looking and breaking it down, look at that bar for black transgender people, 28% unemployment. So the unemployment rate among black transgender people is 4 times the background rate. So Latino, 18% unemployment, Asian is 10%, white 12%, Native American 24%, multiracial 18%. So this is huge. Across the board, everybody has an increased risk. But when you start dealing with some of these intersections of multiple, multiple intersections, you're dealing with race and gender identity, it really starts to add up. This is a chart that's probably hard to see in the back, but these are also results from the National Transgender Discrimination Survey of experiences in public accommodations, what happens to transgender people. So if you look at the first column is denied equal treatment, the second column is harassed or disrespected, and the third column is physically assaulted. So you can see the numbers, they're impressive statistics. Retail store, police officer, doctor or hospital. Let's go down to the bottom. 1% of transgender people said they were physically assaulted in a domestic violence shelter or program. 1% assaulted in a rape crisis center physically. So that's a really big deal. So transgender people don't even feel safe. They're at physical risk. They're at risk of emotional and physical abuse in these basic public accommodations and basic needs getting met. It's not all bad. Transgender people they're very resilient, and they will work hard to get to where they need. 94% of people who reported being denied housing ultimately got housed. 76% got hormones one way or another. Some of them may be buying it from Tijuana or from the street, but they got hormones one way or another. This statistic right here, 78% reported feeling more comfortable and better performing at work after transition. So this is starting to get into some of the why. Why is transgender health important? This was a meta-analysis from 2008. 14% overall worldwide prevalence among transgender women, looking at 14 different countries. 25% prevalence among transgender female sex workers. So you're a transgender woman, you can't get your documents changed, you can't get a job, you were bullied out of high school, you had to drop out of school, you couldn't get your diploma, now you have no skills and you can't get any job, so you're doing sex work. You got a 1 in 4 chance of getting HIV. That's not good. This is a more recent meta-analysis that shows basically a 21.7% prevalence of HIV in transgender women in the United States. If you live in the United States and you're a transgender woman, this study shows that you have a 34 times increased risk of being HIV positive than the general US population. 34 times more likely to be HIV positive if you're a transgender woman. And hopefully the picture I've painted to you is that this is because people have no other choice. They wind up in sex work and other unsafe places. They don't feel like they have any agency over their body. Okay, so let's start talking about some medical care stuff. We talked about why transgender health is important and, why we need to worry about it and who transgender people are and how many there are. What do patients want? They're going to come over to the adult clinic here. They're going to go over to peds at Children's of Oakland. Well, first and foremost, they're going to want hormones. And then the other thing that transgender people are often seeking is surgery. So the bottom line is transgender patients are going to come to you to a medical setting. They're like, I want hormones, I want surgery. That's all I want. So that's what they want, but what do they need? Well, they need a whole bunch of things. They need an accepting administrative and clinic staff. So this is why it's so great to see, basically every department in the hospital is represented here, When you talk about accepting and welcoming clinic and staff, this gets into stuff that we don't really have time to get into it here, but like little things like the electronic medical record. Is there a way to flag that the patient has a preferred name that's different than their legal name? They haven't changed their name yet. So, and the last thing I want to put up here is transgender people need primary care. They need preventive care. They have colons, they have breasts, they have, blood pressures, they have arteries that clog with cholesterol, so they need a doctor. They need primary care. So what can you do? You walk in and you see a patient and you're like, I'm looking at the chart and this is John, but this person does not look like they want me to call them John. You can just say, hi, I'm Dr. Deutsch. Do you have a name that you prefer? All of these little things, really add up. So let's talk some little more medical nuts and bolts here. So what can the hormones do? So we talked about, transgender people are coming, they want hormones. Well, the hormones are going to change all these things. So those secondary sex characteristics that I had talked to you about at the beginning, which are kind of defining your physical sex. So they're going to redistribute body fat. They're going to change the way your skin, your hair, and your nails look, change the way you smell. You're going to grow breasts, or your breasts that you have may get a little bit smaller. The breasts that you grow may not be super big, and we'll show you some pictures of that in a little while. Your body fat will redistribute. Your genitals will get a little smaller or a little bigger. Your clitoris may grow if you're taking testosterone. If you're taking estrogen or testosterone, your testicles and your penis may shrink. Your mind is going to change. So this is a really big one. This is, again, getting into that social part of the transition. Transgender people are like, I want to grow breasts, or I want muscles, but it's like, have you stopped to think about the fact that you're a 29-year-old and you work at Twitter and you are a project manager, you have 10 people who work for you, and you're about to go through puberty? That's a big deal. While you're dealing with all the pressures and stresses of being trans, you're going through puberty. So what about primary care? Well, transgender people need all this stuff. This is all primary care, and they need it. Preventive screening, part of primary care, but transgender people are a little bit different. Transgender people, some of them have a uterus, but they're male. Some of them have a prostate, but they're female. So it's important I keep an inventory of what organs do you have, and then I'll screen them appropriately. So if I have a man with a cervix, then I just screen them. And I don't do I can't really follow those like male and female charts that the U.S. Preventive Services Task Force publishes because they're not gender specific enough for this population. So let's do a couple of quick cases. 32-year-old male to female transgender person referred by mental health for initiation of cross-sex hormone therapy. So this is a transgender person. They went to a mental health provider to try to figure out their gender identity. And then the mental health provider said, you know what, I think it's appropriate time for you to go explore taking hormones. And they came and they are seeing you, and so they're going to start taking hormones. So you do what you do with every patient. You take a history, you do your H&P, get an idea of their medications, etc. I like to get an idea of their support system. I do a little kind of 2-minute psychosocial intake. I like to check their lipids because I'm giving hormones, and hormones can affect lipids. Check their LFTs, because theoretically hormones can impact the liver. It's not really something that's been demonstrated with studies with the type of hormones that transgender people take. And so the different kinds of hormones that you use, estrogens, transdermal, sublingual, or intramuscular, most of the data that shows safety is on the transdermal. This whole risk of blood clot thing is really that's in the past. That was when they were using these high-dose contraceptive type hormones, ethinyl estradiol, 50 to 100 micrograms a day. Those have been moved away from. We're moving away from Premarin, which comes from pregnant horses that are kept in the stable with a catheter. There's no reason to use that unless you like the free pens that the drug company brings. So, bioidentical generic estrogen, estradiol, estrase, works great. It's been studied. There's a much lower thromboembolic risk. And, I'm a big fan. There's a testosterone blockade. This is why I recommend checking their K, because spironolactone, which is an anti-androgen, is also a diuretic. It's a potassium-sparing diuretic, and it can make their potassium levels go up. 5-alpha reductase inhibitors can also be used in patients with contraindications. Maybe they're taking an ACE inhibitor or something, and you're having issues with their creatinine or something. And then progestogens are sometimes used. It's controversy as to whether or not they have any benefit for body and breast development. I think that the hysteria about progestogens that came out 10 years ago with the Women's Health Initiative is really totally overblown. Most of the studies that have been done since have strongly suggest that the problem was using Premarin. I don't know why they chose to use Premarin in all those studies in 2000, 1999, 2002. Now that we're using bioidentical estrogens, especially transdermal, things are much safer. So, monitoring their clinical progress in transgender women, I watch for loss of erections and ejaculate, looking at reduced body hair, skin changes, and fat redistribution, seeing if their breasts are budding and progressing. And then they just need ongoing coordinated care. Wraparound services really are helpful. Again, like I said, most of what I'm doing is case management for these patients, making sure they have support system, community referrals, support groups, discussion groups. They need access to psychotherapy, trans-aware and trans-specific psychotherapy. So a 23-year-old transgender person seeks initiation of cross-sex hormone therapy. So I'm going to go on a couple of tangents here with this patient. One is that you'll notice that this patient was not referred by a mental health provider. So previously, WPATH, which I mentioned in the beginning, who published these standards of care, WPATH version 6, which is now out of date because it was replaced with version 7 this past, or in 2011, it no longer requires that you see a therapist in order to access hormones. And part of the reason they don't require that is because I did a research study that I published that looked at a whole bunch of patients going to different clinics, getting their hormones without a letter from a therapist, and they all did just as well, and nobody got sued, and the regret rate was almost 0, and So there's really no reason to require this barrier. So there's a harm reduction component to this too. Psychotherapy is not available to everybody. So the other tangent I want to go off on is I want to take a couple of minutes to speak about taking care of the little ones. What happens when they hit puberty? Well, when they're getting close to puberty, the kids start saying, geez, my body's changing, and they really start to freak out. And my friend and colleague Jill Olson from Children's Hospital Los Angeles is a real expert in this. She always tells the story of this kid she had who was growing up on an army base, and male to female, they were about 12 years old, they were on 13 psych meds, they just trashed the room every night, they were a total mess. Somebody finally figured out that this kid was trans. And they let the kid socially transition. No psych meds, A student. That's it. Totally fine. So, this stuff makes people feel better and do better. So the issue comes when these kids hit puberty. It's like, well, what do we do? Their body is progressing, and there's the philosophy that if you let a child go through the correct puberty the first time, there's no damage to undo, no emotional damage to undo, no physical changes to undo, and they'll be able to go through all the developmental milestones with their age-appropriate peers. So they'll, they may not be getting their period, but they'll be having breast budding at the same time as other girls in their class. More and more people are starting to argue that we should just be starting hormones on kids, in puberty, just right away. If the family is on board, the social setting is on board, there's some kind of mental health involved that is, agreeing that this is the right way to go. Well, you have a 13-year-old kid. The goal, the point basically is if they hit Tanner stage 2, that's when you say, okay, if the child is still gender dysphoric at Tanner 2, then it's appropriate to go ahead with the cross-sex hormones. Give the child a little bit of an opportunity to experience their natal gender. And if it's still not working by Tanner 2, then they let them go ahead and transition. So kind of the middle of the road kind of approach that is a bit more of the formal recommendation from the Endocrine Society is that you start blockers on these kids when they hit Tanner stage 2. So GnRH analogs, and then you can block their puberty for up to 4 years. People have found there to be no problems, and they all have their bones all catch up. And then they can start hormones. Some of this Endocrine Society recommends at age 16, but sometimes earlier, case by case. So it's really kind of a case-by-case thing. I think the biggest issue that you have to think about with trans kids is if you have a female-to-male trans boy who's going to be in Tanner stage 2 at like age 10, that's not really the right age to start testosterone. That's too young, So those kids might need a couple years of blockers. You can't have a kid be going through male puberty at age 10. It just wouldn't work, enough social issues with these kids. So that's kind of like trans kids in a nutshell. I know it's like probably hours can be spent on it. So anyway, the trans guys are really easy to manage. Remember, we've come back from that tangent. We'll come back here. You give them testosterone and they virilize. It's very easy. You don't need to block estrogen. They do very well. They've researched this. The brain looks at somebody and tries to figure out their gender in the following way. It looks for any male cue. If it finds one, it genders that person as male. If it doesn't find any, then the person's a female. And so this is part of the reason why transgender women have a bit of a disparity compared to transgender men. There's a number of different reasons. Number one, it's more difficult for them to blend into the background and just go about their business. I don't really like to use the word pass because that kind of implies that you're kind of pulling a fast one on people, And that's not really what transgender people are doing. They're just trying to go to Target to buy like a toilet bowl plunger and not be harassed, So the only thing I like to add about this slide, the side effects of testosterone that people talk about, I don't really know that they're side effects because it's like, well, guys get acne when they go through puberty and their cholesterol gets a little higher. So I'm really hesitant to stop somebody's testosterone because their cholesterol is spiked. I just manage them as I would any male with a cholesterol problem, Anyway, so the big clinical monitoring that I do with these people is look for induction of amenorrhea. Do their periods stop when you give them testosterone? And then their follow-up schedule will be similar. So pelvic health in transgender men, they need PAPs, just like anybody else who has a cervix. It's unclear if you need to do any kind of additional pelvic screening, if testosterone confers any additional risk of any pelvic cancers, and I kind of don't want to dive too much into that, but I just want to put it on your radar. This is the self-referral without a letter that I was talking about, and a shameless self-plug for my article. And then cancer risk and screening. I kind of want to go through this quickly, but these are all different kinds of cancers, and that would be of particular consideration to somebody who's got like a gender non-normative body. And so breast cancer, female to male people, we don't think testosterone increases the risk of breast cancer, but it probably doesn't decrease the risk. Male to female people are very, very rare to find breast cancer in male to female people. Ovarian cancer, the jury's out. Nobody really knows what to do about ovarian cancer in non-transgender people. Prostate cancer, well, estrogen's the treatment for prostate cancer, and we don't really see much of it in transgender women. But it's still appropriate to do a rectal exam. You know, we're not doing PSAs anymore for prostate cancer. And then uterus, testosterone most likely stabilizes uterus and causes it to become atrophic. So we're not seeing a huge epidemic of endometrial cancer in these men either. They're amenorrheic, but it's almost all, and it's all atrophy. If they're bleeding, it's almost always because of atrophy. And then the pituitary, you know, estrogen can cause prolactinoma to develop, particularly if it's pre-existing. It's not a very common finding. Some people like to check prolactin first and second year on estrogen. I work in a setting where like every dollar counts for these patients, so I don't often do it. I just watch for visual symptoms, but it's a good idea to check it. So let's go very quickly through a couple of these things. You know, and hormone-related cancers. Endometrial cancer has not been encountered. Only a few cases of hormone-related cancer in transsexuals. They do comment that there may be an underreporting. You know, transgender people, we know that they're so disenfranchised from primary care, so there could be a huge epidemic of health issues in transgender people that we don't know about yet. However, I like to say with these people, there's no smoke, so there's probably not a big fire. So long-term outcomes, this is kind of what I'm talking about. So this is a study of long-term mortality in transsexuals receiving treatment with cross-sex hormones. It's like 1,300 patients over 18 years from the Netherlands. And just really briefly, I don't want to get too much into the weeds on this, but ignore those highlighted areas for now and just look at the SMR, which is the standardized mortality ratio, which is basically your risk ratio. Most of those numbers are very low, and or the confidence intervals cross 1. So we're not really seeing a significant increase in hormone-related mortality. Where you do see the high numbers are in non-hormone-related things. So, you know, AIDS, let's see, illicit drug use, suicide, unknown symptoms. So these are all the high numbers. You know, yeah, there's 1.64 odds ratio of ischemic heart disease, and that is statistically significant. You know, but remember, 32% of these people attempt suicide. HIV and hormones and surgery. So antiretrovirals and hormones, there's not really any significant interactions. Though estrogens don't really impact the antiretrovirals. The antiretrovirals may impact the estrogen levels, which can cause a patient to have like some mood swings and hot flashes and other weird estrogen shifting symptoms. I don't know how clinically significant it is, and it's something to keep your eye on. You know, you put your patient on antiretrovirals and they start getting all these hormone-related symptoms, well, then you might want to adjust their hormone dose because the patient's going to say, I'm going to stop taking those AIDS medicines because they made me feel crappy. So that's really the important take-home. It's unethical to deny surgery or hormones on the basis of HIV status. So don't hold hormone treatment, don't hold treatment hostage. Don't say like, I'm not going to give you hormones until you get your HIV under control. Use it as like a, you know, a carrot on the stick. Be like, great, I'd be happy to take care of your hormone therapy. I also would like to talk to you about your HIV while you're here. You know, your CD4 count is only 126. I put this slide up here because it's going to transition us to the surgery piece. There are definitely some people who are just really visibly trans and they just won't be able to go through about their business, or they won't be able to look in the mirror and just feel complete. And again, getting back to that productivity and, you know, $25,000 worth of surgery versus, you know, the next 30 years of being a very productive member of society. You know, it really, you know, so this is kind of a real hot topic of how do we decide what's necessary and what's beautification. This is someone who's had their Adam's apple removed. It's a tracheal shave. They just do a little slit and they go in and shave down the Adam's apple. It's a quick and easy procedure. So this is a transgender man who had what's referred to as top surgery. What happens in this procedure is there are a couple different approaches. Sometimes they do a little incision around the nipple, and then they kind of leave the nipple attached just by its neurovascular bundle, and they scoop out the breast tissue, sew it back in place. Can't really do that for people who have larger than an A-cup breast because there's just too much saggy tissue. So there's a couple different things that they're doing. One is they're doing these like concentric circle procedures where they're taking a little more and then they do like a purse string around the nipple and then they draw it in. What this patient had, which is a much more common procedure called a double incision, they take two scalpels that are connected on an adjustable width, and they do two parallel incisions. They remove that island of skin, remove all the breast tissue, bring the two edges together, and then they take the nipple and they graft it on into the right place. So that's what this patient had, and you'll see a little bit of a better picture here. This is probably at about a week. This is a patient at about a year. So they wax their chest so that you can see their tats, but they have a male chest contour, and they would have a hairy chest, and you can see that they have generally male kind of muscle and fat appearance. It's pretty good cosmesis. And the gynecomastia surgery that cisgender men have who have gynecomastia, there's a lot of times have a similar scar. So these guys go to the beach. I don't think anybody really thinks twice about what the deal is. It's close up. So pretty good cosmesis. Last couple of slides and then we'll wrap up. So how do you pay for all this? We're talking about insurance, and so there's some like legal and coding issues here. Somebody legally female, legally male, and you're doing a cervical pap. What happens? You send it to the lab, and they're like, we don't have our EMR won't let me order a vaginal pap on this person who's legally changed their gender and is registered as male. So you have to kind of like come up with all these workarounds and call the lab. I've papped a number of guys, and then it comes back read as an anal pap. And I have to call them back and be like, no, this is cervical. And a couple of times it's been changed. I had one guy that got read as normal, and then when I told them that it was a cervix, they reread it as ascus. So that actually, changed the outcome. And then, the whole concept of like the ICD and like coding, I have a slide on that, I think in a couple, but anyway, what diagnosis to use, diagnose gender, gender identity disorder, the DSM. I'm sure everybody's heard about all of this controversy. We don't really have an appropriate code in the ICD. So I use endocrine NOS 259.9. So wrapping up, I told you, who terminology, who transgender people are, how many transgender people there are, some of the health issues and disparities and barriers that face transgender people. Tried to show you why it's important we take care of transgender people and why those disparities are important, how to take care of transgender people. And now, again, coming back to like, why do we do this, and does this stuff actually work? Yep, we've got tons of evidence coming out, including very recent evidence, showing that hormone therapy reduces anxiety, depression, and improves social functioning and quality of life. Well, we know that when we make all of these things better, that people have better health. And that's what we're supposed to be here for, right? So, this stuff just makes people's lives better. We have evidence that shows that surgery improves global functioning and quality of life. And regret rates are extremely low across the board. By the time a patient walks into your office and says, I want hormones, they've been thinking about this for so long. The regret rates are they're just not there. They're just not there. And the malpractice risk is just, nobody's ever been sued for anything. There have been a couple of like grandstanded lawsuits in the media, but not really anything that was legitimate. People sue people for bad surgical outcomes, like you did surgery on me and it went wrong. But that happens all the time. That doesn't have to do with you did surgery on me and now I want to go back. And that doesn't really happen. Surgery in kids, by the way. Forgot to mention this. So nobody's doing surgery really on kids under 18. There's a girl she's like a pop singer in Germany who petitioned the Chancellor of Germany to approve her getting surgery at age 16, and it was approved. There's a lot of debate about what age would you have surgery on kids. It's kind of a hot topic right now, but for the most part, nobody's doing surgery on kids under 18. So American College of Obstetricians and Gynecologists, 2011 December, released a position statement that OBGYNs should be prepared to assist or refer transgender individuals with routine treatment and screening, as well as hormonal and surgical therapies. So this is ACOG. This is like mainstream professional society and this tiny little journal called I'm being sarcastic. This is huge, it's in the Green Journal. And, this is on the mainstream radar now. I think everybody's kind of aware that this is really, this is the hot topic of 2013. Transhealth at UCSF.edu, we have protocols there. We have links to a lot of different programs that we're involved with. I really thank you for your attention, and thank you very much.